Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Otsuka America Pharmaceutical Inc. and Lundbeck Inc.
Good afternoon, everyone. My name is Tom Nyland. I'm going to talk about exploring the role of a psychiatry professional in the care of people with PTSD. I am at the University of California, San Francisco, where I am a professor of psychiatry and neurology. And really, the undercurrent of this title is thinking about how psychiatry and primary care or integrated healthcare models is how we can use that for the treatment of PTSD. And so we're going to talk about a case vignette, and apparently this vignette's been used in previous webinars. We'll talk about strategies for shared care between primary care and psychiatry, including roles and responsibilities. We'll talk about screening instruments, diagnostic tools, and then treatment formulation, and sort of thinking about the division of labor and how treatments can take place. And ultimately, to try to get at how we can think about PTSD in the context of its comorbidities and kind of targeting or personalizing uses of both pharmacology and non-pharmacologic treatments. So this is the vignette. He is a 48-year-old male who presented to primary care for his annual checkup. And his chief concern was just, I'm here for my annual tune-up. But he did report that 4 months ago, he had been in a motor vehicle accident where he'd had minor cuts and bruises. But when asked with more details, he pointed out that he actually saw two people very badly injured, and one of whom had died later on. And then later on, he volunteers that he's actually been on edge for the last couple of months since this accident. And he's noticed a change in his behavior. He's not as engaged with his family. He avoids game nights with his friends. He goes to bed early. And in general, he's been more isolative. And he says he's actually had more thoughts about the motor vehicle accident. So, when you think about interacting with this patient, he's now in primary care. These simple tools, but very useful tools, the PHQ-9 for depression, the GAD-7 for anxiety, and the PCL-5, the PTSD Checklist 5, can easily be done in primary care. And in this setting, he endorses some symptoms on all three of these scales that fit in the somewhat difficult impairment side. And he scores a 36 on the PCL-5. And in general, a cut score of 31 to 33 is roughly where you see a diagnosis of PTSD emerge. So this is somebody who's got significant symptoms of PTSD. The patient is placed on sertraline, followed monthly. He started on 50 milligrams and is titrated up to 100 milligrams in the first month. And by the month 2, he's up to 150 milligrams. And prior to being referred to see the psychiatrist, he reports that he's better. He's had some response, and a workup of his somatic complaints was normal. But he still has symptoms and is troubled by it, and is still not feeling like he's at his baseline. So, this sort of as the backdrop, what are the key aspects of coordinated care? One is that it's wonderful to have psychiatry and primary care embedded in the same integrated care setting. That's a model that's been used in multiple different healthcare systems like Kaiser, the VA, and others. And it's a very powerful approach to coordinated care. It's the role of PCP is to screen for possible, PTSD and anxiety and mood disorders. And the PCP can do the initial screens, provide some psychoeducation, do some initial relaxation or other sort of coping strategies. But then with consulting with psychiatry, the psychiatrist can then use more definitive diagnostic instruments and to think of a, modifying the initial treatment plan for medication management. And then going forward, the PCP and psychiatrist can communicate, outline treatment goals together, make adjustments. And it's this coordinated effort that really enhances the likelihood of retaining the patient in treatment and having a success. So there are a lot of benefits of this model of care. It's easier access. For some patients, it's stigmatizing to go to a primary mental health care clinic. And the other thing is that these screening instruments can take place in just this type of setting where it's an annual physical, sort of the patient didn't present because of the psychiatric symptoms, but the screening instrument detected distress and allowed for earlier intervention. And it's the coordination and the addressing all the needs that the patient brings forth that enhances treatment adherence. And this holistic approach has, been found in multiple sort of health services studies to enhance treatment engagement and retention. So there are some challenges. I mean, primary cares often need additional training to use these instruments and how to sort of work collaboratively with psychiatric or mental health personnel. There is still the problem of stigma as far as some patients just being reluctant to engage with mental health care of any sort, even in an integrated care setting. And then it's true that sometimes access to more complex or specialists who have expertise in more complex cases can be challenging in a more sort of primary generalist setting. So this is the diagnosis of PTSD, and I'm not going to read through all of this, but it boils down to being exposed to a traumatic event and being haunted by that traumatic event in the form of re-experiencing symptoms like intrusive memories or nightmares, avoiding reminders of that trauma, and then changing the way they interact with the world, the way they view the world, becoming more negativistic. And with the D symptoms there, negative alterations in cognition and mood, with a lot of overlap with depressive symptoms. And then finally, the hyperarousal cluster in column number E, the increased startle, the insomnia, the hypervigilance, and difficulty with concentration. And these symptoms have to last at least a month and cause significant impairment for it to reach a threshold for a diagnostic entity. So a good screening instrument for trauma exposure is the life events checklist for DSM-5. And it's a simple 16-item checklist for potentially traumatic events that people may have experienced directly or witnessed in others. And it's another instrument that's relatively easy to give as a screening instrument, self-report, but it also can be converted into an interview to go after more details. And this is something that can be done in either setting. It can be in primary care or with the psychiatrist. And then finally, the gold standard diagnostic instrument, the clinician-administered PTSD scale. This is a 30-item structured interview that covers the 20 DSM-5 PTSD symptoms, the 4 clusters of symptoms that I showed you. It really hones in on both just the last month, but also lifetime. And it represents a change from the prior DSM-4 version. There's now a single severity score for each symptom. And the category of alterations of mood and cognition adds more depressive type symptoms to the diagnosis. And so because of that, the differential diagnosis of PTSD is complex, and Major depressive disorder is in the differential diagnosis and frequently comorbid. A variety of different anxiety disorders, including panic disorder and generalized anxiety disorder, specific phobias, also would be considered in the differential diagnosis. Dissociative disorders, TBI or traumatic brain injury, and then substance abuse, which very commonly becomes comorbid with PTSD. Acute stress disorder is what you see in the first month after trauma, and then it's only after a month that you would consider chronic post-traumatic stress disorder. So there is a lot of comorbidity, and partly because there are some of the items in the PTSD category are shared with other disorders, particularly depression. So negative alterations in cognition and mood are overlap with depression, including anhedonia. And we also have sleep disturbance and poor concentration, irritability. But a couple of symptoms are very almost unique to PTSD. Nightmares are really more specific to PTSD. Flashbacks, intrusive dissociative experiences are something you really only see with PTSD's diagnosis, as well as sort of the general experience of intrusive memories of trauma. So those symptoms can really help you think that, where is your primary disorder. Depression is found in about half of the patients with PTSD, and this is based on national epidemiologic studies in the US. Anxiety disorders are also extremely highly prevalent, as is substance abuse. And, the punchline of the national comorbidity study was that if you had one major psychiatric disorder, and PTSD is considered that now, then you're likely to have two or three disorders. And that's generally true. With people with PTSD, about 80 to 90% of people with a PTSD diagnosis meet criteria for one other diagnosis. And what are they? Well, depression is right up there. Roughly half of men and women, major depression. Roughly half of men with alcohol abuse, less so, more of a quarter of women. A third of patients with PTSD have drug abuse or dependence. Cannabis is a big one, and also meet criteria for other mood and anxiety symptoms. And suicide is elevated in people with PTSD. So there are lots of clinical guidelines that have been published by the VA, the Department of Defense, the American Psychiatric Association, American Psychological Association, the WHO. There are quite a few guidelines. And the punchline from all of these is that in general, psychologic and pharmacologic therapies are considered frontline. It's pretty rare that a pharmacologic therapy can be a first-line and definitive treatment. In general, combining pharmacotherapy with psychotherapy is sort of the way to go in PTSD. Trauma-based treatments, cognitive behavior treatments, are the first-line psychological treatment, and SSRIs have the best empirical evidence for first-line pharmacologic treatment. And in general, in practice, most patients receive both. We also do know that longer-term pharmacotherapy is likely, and it's likely to be required for maintaining improved function after initial early treatment. So what are the options? Both the 2017 APA guidelines and 2023 recommended SSRIs and SNRIs. And to give you an idea where this is coming from, it's actually now been 25 years since the FDA approved a new medication for the treatment of PTSD. So paroxetine and sertraline are still the only drugs that have been formally approved. And because patients often remain symptomatic and have not gone into remission, often people think of other agents to think about for additional symptoms like alpha blockers, antipsychotics, hypnotics, as well as the augmentation with psychotherapy. So we know that SSRIs and SNRIs, they have their adverse side effects, which many people are very familiar with. The AEs are often a driver of non-adherence or irregular compliance. And often people, because of poor clinical responses, consider other agents. And in general, benzodiazepines, which are tempting to use because of the prominent anxiety and sleep problems, have been found to be ineffective for treating acute stress disorder, preventing the development of PTSD. And they have a lot of risk associated with them, including possibly interfering with definitive um, evidence-based psychotherapies for helping with PTSD. And in general, where patients who have mood lability and poor impulse control, there's a risk of benzodiazepines as possibly complicating the clinical picture. So most guidelines actually warn against the use of benzodiazepines. Because of the common phenomena of that patients still have prominent symptoms, even after they've had a significant clinical response with an SSRI, then it's very common for additional medications to be layered on top, trazodone or prazosin or mood stabilizers or antipsychotic or atypical antipsychotic agents. And what I'm showing you with this slide here is a couple of VA studies, just sort of looking at how often people were taking 0, 1, 2, 3, 4, or more, 5 or more CNS meds for PTSD in the VA, and then comparing 2009 and 2019. And what you can see is that one is that polypharmacy is very common, and that two that at least the treatment guidelines do seem to have had some impact on and warning people against using some agents, particularly benzodiazepines. So the numbers of people on 3, 4, or 5 or more medications in 2019 are generally lower than what you see in 2009. This just gives you an idea of what kinds of contrasts have been studied in controlled trials, and placebo, of course, has been in almost all the controlled trials. And so you can see there have been a lot of placebo versus SSRI or SNRI trials, but then you can also see that atypical antipsychotics have been examined quite a bit. And risperidone in particular has been studied and found that in some studies they had to show efficacy, but in the largest study to date did not have efficacy. So most guidelines have sort of warned against risperidone, but have been sort of agnostic about some of these other agents. So what are the advice for adjunctive treatments? Prazosin has been found to be useful for nightmares. Atypicals have been looked at. Risperidone has been warned against because of the large negative trial that was done in the VA. But there's sort of neither evidence recommending for or against for quetiapine or olanzapines, despite small numbers of trials. There's just not enough data on buspirone or beta blockers. There is emerging data, recent data, suggesting that cannabis is actually not helpful for PTSD, and really insufficient evidence for looking at mood stabilizers. Currently, there are some novel emergency pharmacotherapies that are being studied at this point, but across a wild diversity of mechanism of action, including NMDA modulators, calcium channel blockers, even some antiviral agents are being looked at, GABA A modulators. And of course, there's been more work being done on ketamine, but still sort of lack of sort of definitive answers about longer term use of ketamine. Most of the trials in ketamine have been short term, single use or 4-week trials, and the evidence is actually mixed. There is a phase 2 study that looking at a negative allosteric modulator of the alpha-7 nicotinic receptor that's recently completed that shows some promise. And then there are 2 studies that have been applications that have been reviewed by the FDA. One is this brexpiprazole sertraline combination, and the other one is MDMA. The brexpiprazole sertraline combination covers a variety of different mechanisms of actions, including 5-HT1A and dopamine 5-HT2 receptors, antagonism of 5-HT2A, as well as antagonism of alpha-1B and 2C receptors. MDMA also has a diverse mechanism of action, binding D1, D2 receptors, beta-adrenergic, alpha-2, lots of different sites. And I'll show you some data from both of these. This is the brexpiprazole sertraline studies. There are 3 clinical trials that have been done. And here what I'm showing you is a change in the CAPS-5 score, which is, again, the main thermometer for treatment severity. The lower scores is better. So the combination of brexpiprazole in trial 061 outperformed sertraline or placebo. And that's sort of an interesting finding because now it's very rare to see a pharmacologic treatment where one active treatment outperforms another. The same separation between sertraline versus sertraline plus brexpiprazole was found in trial 071. Trial 072 showed no differences across the 3 cells. On the MDMA side, 2 phase 3 studies showed separation between psychotherapy plus MDMA, psychotherapy plus placebo, fairly large effect size in both of these studies. But the FDA was not worried about the efficacy data. It was really worried about functional unblinding and some concerns about recruiting people who had previously had positive experiences with MDMA. So managing PTSD with comorbidities, major depression, if you just focus on depression, you're going to get some help for that. You'll give some help to the patient, but you're not going to really achieve remission. You really need to sort of focus on the trauma and PTSD first. And in general, going after PTSD in the setting of comorbidities is a strong strategy. Doing things concurrently to help with substance abuse or pain has also been found to be a powerful combined treatment approach. It's true with insomnia too. CBTI has been found to be effective in people with PTSD. Prazosin is most useful for people with comorbid nightmares. There's evidence that if you can achieve adherence with PAP, that you can get reduction of nightmares in people with comorbid PTSD and obstructive sleep apnea. And there's this small literature looking at modifications that you might need to consider for exposure therapy in people with mild cognitive impairment. Personalizing care, I mean, focusing on the full diagnostic picture, the patterns of comorbidity can allow you to have a more personalized approach. There are emerging clinical decision-making tools, which I'll show you a slide on that. And then just working collaboratively across the treatment team for, seeking out the patient's input and different clinicians' input on treatment goals. And taking a holistic approach for comorbidity and co-occurrent conditions. And of course, always having the broad view of social determinants of health and cultural sensitivity. So this is the PTSD decision aid. This is something you can find on the National Center for PTSD. It's a very helpful online tool to help you learn about and compare different effective treatments. And just coming back to our vignette, so he was found to have a diagnosis of PTSD using the CAPS-5 instrument that was done by the psychiatrist. It was not being adequately treated with the sertraline. The diagnosis of major depression also, he met criteria, but it wasn't sufficiently improved with sertraline. And so at this point, you would consider a couple of additions to make to the treatment. One is a referral for trauma-focused psychotherapy, cognitive-based psychotherapies, and considering augmentation with an atypical antipsychotic, or for somebody who's not sleeping well, you would consider adding prazosin. And then just to conclude, the strategies for shared care between primary care and psychiatry, has to involve sort of an agreed upon shared workload. and different zones of expertise. Primary care can do the initial screening. Psychiatry can do the more definitive diagnostic testing and a referral for treatment or initiation of treatment, focusing on comorbidities and personalizing use of both pharmacology and non-pharmacologic treatments for PTSD. And then at this point, we can take some questions. I got a question here. I thought paroxetine was not a good SSRI anymore. Bad withdrawal and very anticholinergic. I don't think there's something uniquely problematic with paroxetine. I think it is true that there are some withdrawal symptoms sometimes, but it's actually not unique to paroxetine. And I will say the paroxetine studies that got the PTSD indication from the FDA showed that there was no differences between 40 milligrams and 20 milligrams. So, perhaps a more judicious dose of 20 milligrams of paroxetine would avoid some of those issues that you mentioned here. What is the approach of managing a patient with PTSD unwilling to take medications? That's not an uncommon scenario. And the good news is that frontline treatment for PTSD is psychotherapy. So referring patients for prolonged exposure therapy or cognitive processing therapy or EMDR, these are good psychological treatments that don't necessarily require the use of medications. Can PTSD be diagnosed on the first visit, or does it take more provider-client interactions for clarity? It can be done on a first visit. Of course, it all depends on the complexity of the patient, but it's not like it demands that there be more than one treatment or diagnostic session. In a relatively uncomplicated patient like this case vignette, where there's a single event trauma, a CAPS could probably be done in 40 minutes. So that is not that's not difficult. But very commonly, patients have more complicated histories. They have more trauma exposures from childhood. They've had multiple different types of exposures, and of course, there's the layer of comorbidity that makes the assessment a little bit more difficult. Can you recommend resource regarding cutting-edge interactive technologies such as VR and AI to potentiate the efficacy of traditional PTSD medication management? There's been there are a lot of great resources on both the NIMH, the National Center for PTSD, as well as the International Society for Traumatic Stress Studies. Include some links to some work being done with virtual reality. There's been work done at Emory University. There's been work done at USC. So there is a growing world about how to use, these sort of VR technologies. The AI, I have less to say about, but I have no doubt that this is, a rapidly developing field. But those three resources that I mentioned to you are great starting points for looking for that. So thank you very much. I appreciate you listening in on this and appreciate all the questions that you gave me. Thank you.